quick introduction about Priya. She earned her bachelor's degree in psychology at Northeastern University, and following her time there, she pursued her development of her research skills and her love for research at Boston University Center for Anxiety and Related Disorders, and then UCLA before coming to UH Manoa. She recently earned her master's degree, just this past spring semester. This was her thesis project, and her research interests include dissemination and implementation efforts such as provider trainings, evidence-based assessment, and treatment effectiveness in community settings. Her clinical experiences have been at the Center for Cognitive Behavior Therapy at UH, where she has done a wide array of assessment activities as well as intensive in-home work within the CAMD system. She's been an intensive in-home therapist. And on the DOE end of things, she's done a lot of school mental health services as well. So let's give Priya a warm welcome. Oh, and then one more thing I forgot. If you're on VTC or if you're on Zoom, you can see the slides if you go to helpyourkeiki.com, resources, and what's new. So HYK, Help Your Keiki, resources, what's new, and then there should be a link called upcoming EBS Roundtable presentation. And throughout the presentation, Priya will try to anchor and say where she is at various points during the presentation. Like I'm on slide 5 or 10 or whatever, stuff like that. Okay, is that okay?
Yeah.
Okay, thanks, Priya. Take it away.
All right. Can everyone hear me? I know you guys probably can't. Everyone on the other end? Yeah, okay. Perfect. So again, like Brad had said, I'm really excited to talk to you about a project that I've been working on for a few years now, my thesis, titled The Effects of Workshop Trainings on Practical Utilization Among Therapists in Hawaii's Child and Adolescent Mental Health Division, or CAMD. Just to kind of quickly go over the agenda. What I'll talk about is kind of quickly go over the background of the study, as well as the methods, the results, which I'm excited to share with you all, and then quickly discuss limitations, which will kind of nicely, I hope, lead into a roundtable discussion. So, to kind of talk a little bit about evidence-based practices that are available, I'm going to use this analogy, but like many of you know, there's been a lot of research that's been able to identify and define best practices, which oftentimes are kind of created within a laboratory setting, and so what typically come out of those laboratory settings are manuals, or how I like to call them, or kind of look at them as these recipe books that a lot of therapists have to kind of follow to the T. So if you want to make kind of the best chocolate chip cookie, you follow that recipe and kind of don't really deviate from that. Perfect. And so a lot of what's been great is that we do have these evidence-based practices that are researched and known to work with certain diagnoses. However, some therapists, especially within the community mental health setting, have found that it's difficult to follow that recipe to the T, for example. So you might have an anxious client, but they might also have kind of other symptoms that pop up that you might not be able to use. So one kind of area of research that has gotten some positive attention for its potential is a modularized approach to treatment and training, which we'll talk about today. It's saying my PowerPoint's not working. Okay, it's working.
I thought that was a presentation, just the cookies.
Yeah, I know, it's working the whole time.
Thanks, everyone.
So a modularized approach to treatment and training. So what does that look like? What that kind of looks like is Torpedo and colleagues have actually, what they've done is they've broken down those cookie recipes, for example, and looked at the specific ingredients or practice elements that make a practice work for children. So again, kind of making that chocolate chip cookie, you're able to follow this recipe to the T if that client is pure anxiety, for example. You're able to use each of those ingredients and they're able to kind of work in the evidence-based for that client. However, what happens if you have a client that is necessarily has those depression symptoms, like I mentioned earlier? What modularized approach to treatment allows you to do is add those macadamia nuts or those chocolate chip cookies to make it unique for that client. So it's gotten a lot of kind of positive attention given that community therapists are able to more tailor their treatment to their clients, make that unique. And if you have a preventing anxiety client, you're able to follow that if you need to, but you're also able to have that flexibility, which has been a plus. So I'll talk a little bit about how this relates to my study in a second. But like Brad had mentioned, there were a couple of trainings that therapists were able to attend, which I just want to highlight that CAMD is always at the forefront of kind of dissemination and implementation research. You guys should all be really, really proud. I'll mention a few different ways that you guys are on the forefront, but one is these trainings. And what this was a training that was done in 2008-2009, where CAMD allowed their contract providers as well as those within the Department of Education to attend a statewide training, which actually Scott and Leslie were both at. So I'm excited to hear about their discussion. But what I did, there were three different types of training that the therapists could attend. One was a introduction training, which served as kind of a broad level orientation to child mental health within Hawaii. I won't be looking at that within this study, given that they weren't taught any specific techniques. But they were able to attend to other trainings, which I'll talk about. So one of the trainings was an anxiety training where therapists were taught 5 core anxiety practice elements: self-monitoring, psychoeducation, all the way to cognitive coping. I could have used the cookie analogy. This could have been the chocolate chips within the cookie. However, I want to kind of focus everyone in on how I looked at the practice elements within my study. So I looked at the practice elements as a package. So how the therapists use these 5 practice elements as a whole. Another training that the therapists could have attended was a disruptive behavior training, where they were taught 7 core disruptive behavior techniques. And then again, because CAMD is always at the forefront, there's already been a few studies out on this training data. Dr. Nakamura has come up, did a study on therapists' knowledge and attitudes prior to attending the trainings. And what they found is that those therapists that had a higher degree tended to have greater knowledge of evidence-based practices. And then also, outpatient therapists tended to also report having greater evidence-based practice knowledge. Dr. Lynn and colleagues, what they found was they looked at therapists' knowledge and attitudes changes while attending this training. And so these were, what they found was that the trainings tended to increase therapists' general knowledge of the training techniques for that problem area. However, what they also did find was that the trainings tended to have therapists overgeneralize how a practice element could be used through multiple different problem areas. So they kind of felt like a practice element could be used in multiple different areas. And what I'll talk about that in a little bit more, in that my project is actually an expansion of Dr. Lynn's. And then also just to highlight, Dr. Higgert Millen and colleagues have also looked at client and therapist characteristics within these trainings. And so what they found is the longer a client was in treatment, the more likely they were to get evidence-based practices. And then actually older males who were placed out of the home were more likely to receive minimal or practices with minimal support. So kind of interesting. So like I mentioned, what's my big picture of this study? While Dr. Lim looked at a lot of different client or therapist characteristics that may have changed their knowledge and attitudes after the training, we wanted to expand it by looking at, did that change their behaviors? So we're looking at, did the therapists who attended the training, were they more likely to correctly use those trained techniques? I'll just quickly go over the inclusion criteria for both participants, whether they were therapists and clients that were included within the study. I'm on slide 11. Sorry, I've been kind of bad telling you slides. Okay, so slide 11. So therapist participants, they actually, so I did use a subsample of Dr. Lim's research project, in that he used both the CAMD therapists as well as Department of Education therapists. I only used CAMD therapists because they, the CAMD therapists actually have the practice data that we use. And I'll quickly touch upon the NTPS, which is where we get the practice data. The therapists had to attend the anxiety training and or the disruptive behavior training. What you'll see here, it's a go off, but there are 27 therapists attended the child behavior training only, 11 attended the anxiety training only, and 9 attended both, actually. And pretty typical, they were mainly female therapists that were an average age of 41. For client participants, what you'll see here is because CAMD has such an array of data, there's so much, which is absolutely amazing. I was able to use 1,922 youth. 778 were treated for anxiety, and then 1,144 were treated for disruptive behavior. The ages were pretty typical, it's around 12 years old, and the majority of them were male. And I'll go into the inclusion criteria a little bit more just as an example, but we took the first 180 days of treatment, kind of first 6 months, and the children had to be seen completely before or completely after training. So I'll show you a picture that might give a little bit of a better picture. So those clients who were seen while the therapist attended the training, so like youth 3 and youth 5, were not included within the study. And again, the lines represent the first 6 months of treatment. The measures that I used within the study, so I did, to get the background, I used a therapist background questionnaire, slide 14.
Thank you for doing that.
Yeah. For attitudes, we use the modified practice attitude scale, and I'm going to go a little more detail about the knowledge and practice measures. For the knowledge, we looked at the knowledge of evidence-based services questionnaire, which if you've been to multiple EBS meetings, I'm sure they've used that a lot. And then practice, we use the monthly treatment in progress summary form, which I'm excited to show you. So for the KEBS-Q, or the knowledge measure, what we looked at, the KEBS-Q has kind of it's an amazing ability in that you can score it in multiple different ways, and it looks at therapists' knowledge of a specific practice element, and basically if they know which problem area it's best known for. So, for example, this item 1 is talking about the practice element of exposure, which is a practice element that's derived from the evidence base for anxiety. So you have A, that's anxiety, depression, destructive behaviors, hyperactivity, and then none. So this therapist would have gotten 1 point for circling A correctly. Rather than using a total score, which is 0 to 160, we looked at it as a target score, because we're trying to really look at therapists' knowledge changes of those specific training techniques. So we looked at, since they were taught 5 anxiety techniques, we looked at the 5 practice element items. So the score goes from 0 to 5 for their anxiety target score. And then for therapists who attended disruptive behavior, it was this KEBS-Q disruptive behavior target score, which was from 0 to 7. Now the MTPS, or the monthly treatment progress summary form, is another amazing way that CAMD kind of always at the forefront. In that this is a measure that asks therapists what practice elements they use each month. So again, it's kind of a pretty rare measure that a state has done, in that the therapists actually have to fill out, and it's tied to billables, but they have to fill out what practice elements. So we've already broken it down by practice element they use with each client every month. This is an oversimplified version. It asks about different service settings. It asks about progress ratings. And then 2 other sections are the targets and practices section. So these are the 2 areas that I'll be looking at within my study. And I'll show you a little bit how that might look. Again, oversimplified version, but what that might look like for my constructs. But I have to show you the constructs before I do that. So what I did there were 2 different outcome variables. There was a true positive and a false negative. Try to go through this kind of slowly because it starts to get more complicated a little bit. But these are 2 theories that are derived from signal detection theory. The true positive is basically asking, did the therapist use a technique when they were supposed to? So what you're looking at is you have a child that's anxious. Did they use exposure, which is the practice derived from the evidence base for anxiety? Now, false negative, basically the opposite. So did a therapist not use a technique when they were supposed to? So you have an anxious child, and they didn't use exposure. to show you a little bit and try to put it into a slight context. We have true positive Teresa. We have Johnny, who on the MTPS has the treatment target of phobias and fears checked. And true positive Teresa did use exposure when she was supposed to. So on the MTPS, what that looks like is she circled phobias and fears, and she circled using exposure. Now we have false negative Fiona. Not perfect, but she also had Sally, who had a phobia of storms, but she didn't use exposure. So I'll try to kind of reference Fiona and Teresa throughout this, but this is what Fiona's MTBS would look like. She did have the target of phobias and fears checked, but didn't check exposure.
Priya,
Yes.
because I think a lot of stuff hinges on this idea.
Yes.
Let's ask if there are questions or comments first.
Yeah, totally.
Just real quick,
Yeah.
you say, you used the phrase in the previous slide, appropriate use, or do you mean just like no use? No, distinction.
Good question. So, the next slide might get to that slightly. In that, so I'm looking at the false negative is they failed to appropriately use that technique when they were supposed to. So they should have used exposure throughout the 6 months of treatment. And it's like yes or no in the way I coded it, if that makes any sense. So it's, did they use exposure at all during that first 6 months of treatment? So it's a yes or no on that. Hoping this is answering your question. No?
Well, I think so, because there's probably within exposure, there's multiple, I guess you can do a few things within exposure, and not the whole package was
Correct. It's
used.
not. Yeah. So it's not a fidelity marker in terms of quality of it. It's just by appropriate. It just means was it in the. So if they check the anxiety target, we would expect them to check exposure on the MTPS.
Does that make sense?
So I'm a layperson, forgive me.
Please, yeah, that's great. No,
And I've been struggling with this for a long time.
Yeah. we all have.
I understand practice elements, but I do know that some hold a bigger bang for the buck. So
Okay.
with anxiety, exposure is a big one.
Mhm.
Whereas some of the other elements you have there maybe have less of an effect on the child's symptoms. And I'm wondering, in your study, did you grade them all at the same level of impact?
We did, because all 5 of these are derived from the evidence base to work for anxiety, we just kind of used it at the same impact. So we didn't necessarily say the exposure had more weight than the other.
I have a question for later, but I'll wait until we get to it.
Okay, yeah.
And then I think. Oh, sorry.
No, I just wanted to, I can't read the one in blue. What is that?
Oh,
say?
sorry. Self-monitoring.
And then in terms of the related to that, Susan, I don't mean to put Leslie and Scott on the spot, but I think that they did incorporate that and put some careful thought into which particular 4 to 6 elements they would be training on. So for the anxiety trainings, I think you guys did try to focus on some of the heavier hitters. Is that true?
Yeah, I mean, I really tried to teach people exposure. Partly because it is a big bang for your buck, but also because I think people don't know how to do it. And I have to say, I honestly had a lot of concerns about whether they left really knowing what I was talking about. So, I mean, it was a quick day to try to get a bunch of information out. You know, you worry that a little information is worse than none, but
Yeah, I'll be interested to see what you guys think of the results actually too.
Thanks, Chris.
Does that answer your question? Do you see all the other ones? Yeah. All right. So, I guess to try to define true positive and false negative just a little bit more, I think I already touched upon it a little bit, but we're trying to look at how much of the package did that therapist use correctly for they, with this client Johnny, they used 3 of the trained techniques, but didn't use 2. So for a true positive rate, you're going to see it's a 3 out of 5 rate. And then the inverse is their false negative rate, and so that would mean that they failed to appropriately use 2 out of the 5 anxiety practice elements that they were taught. I'll stop for questions here too, just in case. Yes.
They use 2 inappropriately
Yes.
and use 3 appropriately.
Yes. So they were supposed to
So-
use coping and self-monitoring, but they didn't. So they are inverse of each other.
Yeah, exactly.
Yes.
Okay.
Yes. Any other questions? So we did use a cross-classified multi-level modeling. Just to kind of give a little bit of a generic model, there was 3 levels. The first level was the MTPS, as well as the training data. And then the second level is client characteristics, and the third level is therapist characteristics. So what we expected, I'm just going to go over the hypotheses. What we were hoping really was that over time, therapists would more correctly use the trained techniques. After the training, we would hope that they're more likely to correctly use the techniques as well. And then with more knowledge after the training, we would hope they more correctly use the techniques. And then for after the training, if they had more positive attitudes towards evidence-based practices, we would kind of hypothesize that they would be more likely to also use the trained techniques more correctly. And that was for both trainings. And then for the false negatives, kind of the complete opposite. So we would hope that over time they'd be less likely to fail to appropriately use them. After the training, more likely to not use them, fail to correctly use them. And same with functionality. So I'll go over the